Hopefully you can hear me. Thanks, Barbara. So I'm a liaison psychiatry consultant. I've been working at Charing Cross A&E for the last 8 years, very closely with Barbara. The last topic was not the driest topic. I think this one is. So I'm going to talk about standard 5 parallel assessments. I mean, when Barbara asked me to talk about this, I was quite surprised that this isn't happening everywhere. I've prepared 5 slides. I'll be 5 minutes. So I think it's important not to, I'm sure we all know what parallel assessments are. So the idea, I guess, is that a patient comes in, is triaged in ED, and if there's a need for a medical assessment, that occurs in parallel with a mental health assessment, if that's required as well. And that's contrasted with linear assessments. So a request, for instance, by mental health services for medical clearance before being seen. I think often there is some confusion between medical fitness or fitness to be interviewed or requests for medical clearance from psychiatry. And these are sort of different issues, really. So fitness to be interviewed, obviously, if the patient is semi-conscious, we won't be able to do an adequate psychiatric assessment, but we may be able to aid in department management. Requests for medical clearance as well often come from other people, probably outside of the department. It could be 136, for instance, coming in. There could be a request for medical clearance, but that's a slightly different issue. Benefits of parallel assessments, I mean, these are quite obvious to me and hopefully to everyone else. So it allows responsive, accessible care for patients presenting with a mental health crisis. It obviously helps reduce lengths of stay in the department, not sort of doing things in a linear fashion. It can also help aid medical management decisions. So things like patients who've come in having self-harmed, who are refusing or declining management of the self-harm. We may be able to facilitate decision-making around the Mental Capacity Act, as well as assessing and managing mental health problems at the same time. Risk management, we've talked, I think there's been some talks about risk management. We have a wealth of information on patients presenting, which we can share and help in department risk management. So we can guide, how the RMN should be managing the patients. Should we be worried if this patient absconds, for instance? And I mentioned patients who are not fit for interview. We do like to know about patients in the department, even if they're not fit for interview, because we can start the process of assessing, we can gather information, but we can also give guidance, as I said, to patients who need some risk management in the department. I think this also helps with interface dynamics. We sort of feel a bit more embedded part of the team if we're working together, A&E and mental health teams. And in some cases, I'm thinking more about high intensity users. So these patients may come in, we may have all the information, we may be able to help guide medical management of patients presenting with things like somatization disorder. I borrowed this slide. This just shows parallel assessment. So this is good practice, basically. So a patient comes in with a mental health symptom. So it's identified at triage. If there's no other medical issue that needs assessing in the ED, straight from triage, referred to mental health liaison psychiatry and assessed by liaison psychiatry. Now, if there's self-harm, both the psychiatric assessment and management should take place in parallel with the medical investigations and management. If the patient comes in intoxicated, that doesn't exclude us coming down to see patients or accepting these referrals. So we can come in and manage these patients alongside ED managing intoxication states, and often that's just time that's required here. There's a special sort of case for older people who may present with some sort of confusion. There is often, a focus on ruling out organic conditions, and that's just because those are much more common. So the purple here is sort of ED, doing more of an in-depth assessment before a potential parallel assessment here. I was wondering, whilst thinking about this topic, why do linear assessments still exist, if they do exist? And I have actually heard they do exist in some parts of the country. So some of the old models of liaison psychiatry splits A&E psychiatry, A&E mental health from ward mental health. They can have, so some places have two different teams. I put sort of focus on operational aspects. In my mind, that means often there are decisions about where someone's going to go after their spell in A&E. So if patients can be admitted under medics, for instance, that's in some ways we know where that patient's going to go and can continue the mental health management there. I'm not saying any of these are good arguments for having a linear assessment model. I think sometimes something that's just not talked about much, I think, is time. Often with time, and you would have seen this with a lot of your patients in crises, time de-escalates distress. So by waiting for medical clearance, we may have a more accurate, an opportunity to accurately assess someone's mental state and make onward plans. So there's a sort of, that's not a very, it's like the almost opposite to a dynamic assessment process. Some areas also may not have the resource to do multiple A&E assessments. So there could be an argument that there's an efficiency in doing just one assessment when you know if a patient's going to be admitted or discharged. I'm not saying any of these are good reasons to continue doing this. And the main endorsement is in this document, which I think has been circulated before this meeting. It's endorsed by all the Royal Colleges, the Psychiatric Liaison Accreditation Network, which is a quality improvement program within Royal College of Psychiatrists. So all liaison services that want to get accredited as excellent with the Royal College have to offer parallel assessments. And the NICE guidelines also endorse parallel assessments. I'll stop there. I think that's 4 minutes.
Well done, Sachin. Thank you. Dion, you've got a quick question. We'll take one question and then we'll move on.
Yeah, I think somebody's also referred to this in the chat, but we have a fit for assessment document which lies on psychiatry. And I'm just going to, there's one line I want to read and get your opinion on, which is the following. There is little point in doing an immediate assessment for a patient who is likely to receive prolonged treatment in ED and consenting to this. Discharge and safety plans are best made close to discharge, which they often use as an argument for patients on NAC, that, you know, so much can change in the next 12 hours or whatever if you use SNAP or whatever you use. So why should we come and do it now?
I mean, my response would be, see, this is where I think if you see a liaison assessment as just the sort of one-off intervention, which is very formulaic and designed to sort of signpost, then fine. But, you know, it's not. We provide all those other things. There's a sort of therapeutic intervention being provided. There's value in gathering the information early on. As I said, all those other benefits, you know, in terms of addressing someone's immediate distress in the department. You know, these are things we should be doing. I mean, that document is a mental, where is that document from? Is that just
that's something that our liaison psychiatrist wrote as a guide for us.
Yeah. I mean, we do sometimes, you know, we do come and our initial assessment, if we know a patient's going to be in the department for many hours, it may just be to introduce who we are and to say that we'll come back later. It can be as little as that. It's some sort of contact. Some sort of face-to-face contact. So it's not, I think maybe, you know, you need to take that back. It doesn't need to be the whole assessment.
Yeah, absolutely. Can I just say on that joint assessment, the side-by-side document, the one thing that I've always picked up is in the first block on the left, it says more than 65. And I'm sure that should be less than 65.
Yeah, yes. Yeah, that is incorrect.
Yeah. So
I've never picked that up.
Yeah.
Dion, your hawkish eyes, it's very useful.